Welcome everybody to the first annual Joint Eastern Medical Research Pre-Conference Workshop that is entitled Encouraging Diversity in Research, a Shark Tank Approach to Solutions. I'm very excited about this workshop. My name is Pat Bugan. I'm a pediatric endocrinologist and an associate professor at Columbia Hospital. First of all, I have to say I'm a minority, I'm Latino, and also foreign medical graduate. I'm very likely to be the chair of the Diversity, Equity, and Inclusion Committee at the ESPR. Other members of this committee is, besides myself, is Suhasini, who's my co-chair and who's also one of the sharks today, Mitchell, Onami, Priya, and Elisa. And also Priya is one of the sharks who is sharing this workshop with us today. What would we do? Okay, so let's see. Our mandate as a committee is to promote awareness and diversity, equity, and inclusion, or DEI, within all the committees, offices, and members. Also, our tasks include actively diversifying memberships and leadership, representing the board on that matters, and also supported initiatives as the one that we have today that will help direct the course of the ESPR in such related matters. What are our responsibilities? To develop regular sessions. So far, this is our second session. I'm going to explain to you in a second. That is virtual, with invited speaker to address topics that enhances DEI within the medical research community. And also to develop mentoring and, most importantly, networking opportunities between seniors and underrepresented junior members. And that's one of the things that we want to do during this workshop. We had in 2021 a very successful program that it was entitled Mentoring, Investing in Youth Underrepresented Research, Investing in the Future of Pediatric Research. During that particular workshop a year ago, we have 4 different speakers. And the speaker talked about imposter syndrome, microaggression and race, building and maintaining a diversity and inclusion program in academics, and how to get the most out of your relationship with your mentors and sponsors. And we recently published the whole program in pediatric research. Actually, here you can see that's the reference, so you can look it up. And actually, it's a very interesting commentary. And this year, we decided to do something different. We really wanted to invite early career and trainee researchers who represent diverse minority groups as myself to come and pitch their ideas on how to enhance diversity in research to a panel of judges, the sharks, but actually, as we said, we are not really sharks. The session was based on the TV show Shark Tank, where investors pitch their product ideas to a venture capitalist who in turn provide feedback, and in this case, also some money, to get the project off the ground and into the marketplace. So furthermore, I'm very passionate about what I do and about increasing diversity in the research arena in terms of age, race, religion, nationality, sexual orientation, gender identity, and national origin. Because we think that we can bring this very diverse group into the scientific community. So without further ado, I want to pass it on to my co-chair, Suhasini, who's going to introduce herself. Thank you and welcome everybody.
Hello everyone, a warm welcome on behalf of the Diversity, Equity, and Inclusion Committee of the ESPR. My name is Suhasini Kaushal and I'm the co-chair of the DEI Committee of ESPR. I'm an assistant professor in pediatrics in the Division of Neonatal Perinatal Medicine at Georgetown University School of Medicine and MedStar Georgetown University Hospital. I feel very privileged to have an opportunity to serve as the co-chair of this DEI committee. Our committee already consists of a diverse group of individuals from very different backgrounds practicing their craft in very diverse setups. And I can say already that within the past year, since the inception of this committee and this collaboration, I have already received great mentoring and guidance, and that has really helped me grow. I'm also a foreign graduate from India and completed a residency in OBGYN, pediatrics, and then pediatrics, and a fellowship in neonatal perinatal medicine. So along the journey of my chosen career path, I have learned the importance of mentoring and mentors along the way. Mentors come in all shapes and sizes and forms, and guidance comes from all kinds of corners. Mentors may or may not look like you, but the guidance is invaluable and takes you a long way in all walks of life, both personal and professional. As a member of the DI committee, I hope to help with furthering our mission of collaboration and creation of a network of mentors that can encourage a diverse research workforce of physician scientists. And as a shark today on this unique platform, I look forward to the ideas that our presentees have that will provide more opportunities for increasing diversity, equity, and inclusion in the pediatric workforce. I also would like to take this opportunity to extend an invitation to all our attendees today to become a part of this committee and this organization and avail of the platform and opportunities that are presented to all of us as pediatric research. Welcome. I'm going to pass on the baton to Dr. Sripriya Sundararajan, who is also one of our members of the DEI committee, who is also one of the sharks today.
Okay. Thank you, Suhasini. Welcome, everyone. My name is Sripriya Sundararajan, and I'm an associate professor in the Division of Neonatology at University of Maryland School of Medicine. It is my honor to serve as a DEI committee member of the ESPR. I collaborate with and support ESPR members in implementing the mission of this committee, which is to promote diversity, equity, and inclusion and carry out the required responsibilities with utmost diligence and integrity. I'm a foreign medical graduate, like so many others in this forum. I'm originally from India. I'm a pediatrician from India, and I came here to the West for some more training. And early on in my career, I realized that understanding one's cultural background is most fundamental to understanding one's behavior. And before one can set expectations in the workplace, be it the workplace or any place where you go, one must understand and approach the employee or co-worker with open communication and willingness to be inclusive. And I'm very passionate about increasing diversity in my workplace. And just over the past year as a DEI committee, I have learned so much from this committee, and we want to pass it on to the rest of the community as well. Now, as a shark for this upcoming forum, I'm interested in hearing more about programs and ways by which one can promote diversity in the workplace that'll benefit not only just a close network of physicians, but also other trainees and staff members. So good luck with your talks, and we are very eager to hear from each one of you. And again, thank you for your participation. And regardless of who's the winner, I think all of you are winners here. We looked at your proposals and awesome ideas. Yeah, so good luck.
Thank you, Sharks. Good afternoon again, everybody, as we have some other attendees coming in from our statistics session. Welcome again to this session entitled Encouraging Diversity in Research, a Shark Tank Approach to Solutions, which is sponsored by Abbott Nutrition. My name is Vivian Yap. I'm a neonatologist, just like a few of your sharks today, and I will be moderating the session and will give you some housekeeping overview for this session. So we have 4 participants today who will be presenting to the sharks. Each of these participants will be introducing themselves, their interest in this field of diversity, equity, and inclusion, and then their project proposal for about 10 minutes. Just like in the TV show Shark Tank, this panel of judges or sharks will ask you questions about your proposal. But as they said a few minutes ago, they're not really like the Mark Cuban kind of shark. So they're not going to be not so much of a bite. We will also ask the audience to type in questions in the Q&A section of the Zoom webinar. Please note that there's a comments section within the Attendify platform, but those comments we won't be attending to live during this session. You can also contact any of the attendees or sharks through the Attendify platform and locate each of the sharks or the presenters. The presentations of each of the proposed projects of our participants today will be judged on a few factors. They'll be judged on feasibility, innovation, impact, novelty, ethical principles, and reproducibility. The winner this afternoon will receive a $500 prize to be applied towards their project and a complimentary registration fee to PAS 2022 in Denver, Colorado. We have 4 participants in today's Shark Tank. Ms. Kezia Edmonds, who is a research assistant in the Department of Pediatrics at New York Presbyterian Brooklyn Methodist Hospital. Dr. Cynthia Perez, a first-year neonatal perinatal medicine fellow at New York Presbyterian Weill Cornell Hospital. Dr. Alicia Quinchette, a third-year pediatric rheumatology fellow at Children's Hospital at Montefiore. And Dr. Sandy Dorsalis, an assistant clinical professor at NYU Langone Health, Long Island. We will start with Ms. Edmonds. You can go ahead and share your slides. Can you unmute yourself, Ms. Edmonds? We can't hear you. There you go.
Yes. Can you hear me now? All right, perfect.
Yep,
So as was already said, I'm Kezia. Nice to meet you all. And my presentation today is entitled How Cultural Norms Hinder Diversity in Research, Increasing Self-Awareness Through Meditation with Culturally Diverse Music to Elicit Internal Biases. So for a brief introduction, I have completed 2 bachelors at Brooklyn College in New York City, a BS in biology and a BA in psychology. And during my time there, my senior thesis involved industrial organizational psychology research, which involved 3 years of looking at information elaboration as a mediator of diversity and team performance in the workplace. And for those of you who are not familiar with information elaboration, as it sounds pretty much, it involves how elaborative employees specifically are with each other of the information that they have and the impact that that can have on long-term productivity. And another project that I also worked on at my time there was on teamwork in healthcare and the handoff process. Most recently, I have spent 3 years so far as a research assistant voluntarily at NYP, Brooklyn Methodist Hospital, with Dr. Nitin Ron as my PI. I have helped with initiating a research project on meditation, looking at that as an intervention to decrease burnout in pediatric residents specifically. But thankfully, we've also been able to incorporate that into other departments, including pastoral care so far. And if you look on the posters that will be presented at this year's ESPR, Dr. Ron is presenting 2 of them from that project. So some things that I did to help with this was reviewing the curriculum that they had so far and initiating a dialogue between all team members regarding improvements that were needed. And the outcomes of this were very good in terms of survey compliance, showing a 30% increase overall. And much improvement was noticed in the quality of the questions as well. I was also able to help edit one of their books that they published on meditation techniques. So as an overview of what I'll be discussing today, I'll first go over my focus in diversity, looking at surface level versus deep level. I'll also cover cultural norms, cultural adaptation, building of trust and its importance in all of this. And finally, I'll have the meditation project proposal to increase self-awareness among researchers and incorporate a multicultural approach through music. So to begin with background and my focus, I was diagnosed with epilepsy at age 4, and for me, growing up, knowing that I had that diagnosis at such a young age, it became ingrained in me pretty early on, and I found myself seeing things through one lens, and I think being pretty short-sighted about my ambitions or skills moving forward. And I think it wasn't until high school years that I found greater freedom through mentors and thankfully other people who intervened and helped show me the skill sets that I had. I was also raised in a small rural town in New Hampshire, which led to more isolation in all of this. And thankfully at age 18, I had the opportunity to move to New York City, which was quite a culture shock, but also led to me being exposed to way more of the realities of what diversity means and all of the issues that still have to be worked through. So diversity is not just about appearance and characteristics you see, it's the entire person and will change over their lifetime. Thinking of it in a strictly ethnic sense, which is how I was initially taught about it, really ignores the influence of many other factors. So just as a brief overview of what surface versus deep level refers to, as this is more of an IO psychology topic. Surface level basically means first impression that you have just from a very brief interaction with someone. And at that point, you don't really know them that well. It's anything easily observed. Versus deep level being not readily seen. And that makes it a potential threat as you don't really know the person. But that's also a source of greater outcomes if you can understand it. So here I put together a diversity mind map to focus on diversity broken down into surface level versus deep level with examples of each connected to them. And on the next slide, I would like specifically within deep level to focus on cultural norms. So cultural norms are basically expectations or rules which guide our behavior in social groups. And it's notable that they do operate on a presumed commonality. So I've emboldened the word presumed here because it isn't often really a commonality. We think that we have things in common with other people, but this all goes back to grouping behavior of humans and a way to protect ourselves by assuming, oh yes, we do have things in common with them or we don't. And that can be really misleading. These are usually unconsciously ingrained from a young age and inform our communication and behavioral assumptions with others. And connected to this, I want to touch on cultural adaptation. Generally, there's an adaptation of new with retention of old. And this plays out very importantly at home versus the workplace. If you look down at the bottom, I've created a picture of essentially a continuum for cultural adaptation, where at one end you have traditional, referring to what you've grown up with as cultural norms. And at the other end, you have the new culture, which within IO psychology could be seen as the workplace. And the assimilation usually tends to be somewhere in the middle, but typically people will tend to hold on to those traditions more so, even if they want their behaviors to say otherwise, that they have assimilated. So communication challenges can arise from this, as by nature, most people will not indicate that their norms are being transgressed. And these constant violations result in a baseline stress for people. And even if they don't say it, they will show it through their actions, including poor performance and long-term retention challenges. So what can we do to change this? We can look at leaders striving for conscious awareness of their own biases and cultural norms and setting an example for those around them. We should also be reevaluating the structure of any way that we present this. Finally, retention of employees is crucial for long-term success with this. And whether you're prioritizing income, which would be from a very administrative standpoint, or well-being with an employee-focused standpoint, the outcome is still best when employees are prioritized. As a valued employee or researcher or healthcare worker will invest back into their employer. I also want to touch on why team building activities can actually be detrimental. As this approach traditionally will focus on surface level issues, making it more of a quick fix, and usually completely neglects the deep level issues, which are at the root of the cause. Most efforts to boost morale through this technique is lost long-term and ends up with everybody defaulting back on their cultural norms, like what they began with. Instead, we should be shifting our focus towards the deep level issues, such as the internal biases arising from the cultural norms. So how do we start with this? We should consider practical relevance, as there is no one size fits all. We should really emphasize open communication, which can lead to honesty regarding cultural norms. And we should be sensitive to the strengths, weaknesses, and biases that everyone brings to the table. And note that weakness in one environment is a strength in another. And finally, tolerance is not the answer, true understanding is. And here are just a couple of brief examples of how teamwork does not always work out best. Something else I did want to include here is trust, which is fundamental to encouraging internal exploration. And we have incorporated this in our meditation curriculum so far through fostering a communal effort with our group feedback sessions, where all of the residents that participate in meditation are allowed to let us know what is working and what is not. And this opens a line of communication for all, making it easier for them to share what's happening internally, and then through their experience is increasing their self-awareness. I also included a quote here, which I think summarizes it really well. And it reads, "It is not the degree of difference between groups that causes harm. Rather, it is the lack of skill in identifying breaches of trust based on ethnic differences and the lack of skill in restoring trust once it is broken." So for the methodology of this project, this would be phase 4 of an existing IRB approved project, incorporating cultural awareness into our study to embrace deep level diversity and encourage trust. Meditation is used as an intervention to reduce burnout, and this study has been active since 2019. The questions that we've implemented focus on self-awareness and related traits during the meditation session, tracking the progress over the entire study. A key aspect that we've also observed is the positive correlation between involvement and participation. So we have ambassadors who are trained participants and lead weekly sessions as well as participate in the study, and they are way more engaged in the projects compared to those who are not. As an overview of our project so far, it's a 3-month-long project for each session, and each one involves monthly 45-minute sessions, with number 1 being an introduction to mindfulness and meditation, number 2 incorporating that feedback at the midway point, and then number 3, a final debriefing of the strengths and weaknesses of the curriculum. We've incorporated the following standardized surveys administered at baseline and final sessions. And we chose the Oldenburg Burnout Inventory and the 5-facet mindfulness scale for this. We also incorporated the Toronto Mindfulness Scale as a way to see right after they've completed each meditation session, how they are currently feeling. And this picture gives an overall timeline of how everything comes together with the modules, the initial and final survey, and those 12 weekly sessions. So specific aims of this project include closing the diversity gap through increasing awareness of cultural norms and cultural adaptation, recognition of common breaks in trust, and rebuilding them through communication. and incorporating meditation music from various cultural backgrounds. We'll also be implementing 2-minute runs of EEG, both before and after each 5-minute session, as we have those headbands that we can implement easily for that. We also plan to expand the number of groups and sessions that are run during the week and train more ambassadors for this, with a twofold benefit of increasing flexibility for all attendants and having a smaller ratio of ambassadors to participants, which will increase the opportunities to build trust. So for strengths and limitations, the strengths are having structure of an IRB approved study already in place for this. We've had experience troubleshooting problems during previous phases, which we can bring to this new one. And we have professionals on board with years of meditation experience. Regarding limitations, incorporating culturally diverse music to reflect the cultural norms can influence how people experience their meditation. And in previous studies, we have seen that the best data does come from playing the same exact recordings repeatedly so that you have a standardized baseline for this. However, after doing more research, I found that incorporating questions to account for people's background coming into the study and then how they will interpret those different types of music should be able to account for this. Another challenge we've experienced with every single part of the study so far has just been general retention, as a lot of the residents really show lack of interest by about mid-study. And going forward, something we've been trying to implement every time with some improvement is just refining the phrasing and trying to incorporate direct participant feedback based on what works for them. So in conclusion, diversity in the thought process of team members provides a solid foundation for a non-biased, inclusive outcome that better serves the research community and fostering trust in each other and commitment to the team. There is a need to reevaluate the priorities of medical training programs, normalization of overworking, and the underlying stress that occurs throughout training and beyond, as this results in disillusionment and decreased interest in burnout prevention, which is a key factor in delivering high quality patient care. Essentially, if you're too burned out, you won't even be interested in any of this. Open communication between researchers is key to raising awareness of the ingrained biases that can harm us long-term if left unresolved. And the multifaceted nature of diversity makes it hard to understand, but the challenge that it prevents us should motivate us to conquer it and not recede into the default of our cultural norms. In closing, this is one final thing that I had, and any questions? Thank you.
Thank you, Ms. Edmonds. I don't know if Sharks, you want to start asking questions, or I can ask, we'll hear from the, one of the Sharks first from the Sharks, and then we will ask these questions in the Q&A.
So I'm interested to know who are the ambassadors and what kind of ethnic background or what are the characteristics of the ambassadors that are working with you with the meditation?
Yeah, great question. So the ambassadors are essentially residents who would already be participants in the program, but instead of simply coming in for every session and listening and participating in that meditation, they receive extra training from Dr. Ron specifically on how to lead a meditation session with just the basic needs of how to play the music and how to put on the EEG to test for all of that. So after they complete that, they are also participating themselves in other sessions. So it's a twofold benefit where they're the leader, but they're also participating.
And when we talk about this are, for example, minority, people, underrepresented residents, did you look into that? Male, female?
Yeah, so I did not look specifically into the breakdown, but I have noticed in general, it's actually a higher percentage of females which participate, which has been found across all research studies in general. We found that to be the case with ours. It's roughly about 4 to 5 females for every 2 males that participate. But beyond that, I would say the minority groups are very high simply because it is Brooklyn, New York that we are doing this study at. And so I think the residents that are attracted to that program naturally will be coming from more of a minority background from what I've seen. So it is majority of them would be considered a minority background.
Thank you.
So I would like to first say thank you for introducing us to the concept of IO psychology and information elaborative concept that you explained about diversity. I really appreciate that. Thank you. That's a new concept to, I think, most of us. I am blown away by the diversity mind map and the deep level and surface level, the analytics, and definitely gives me a better understanding of how much the deep level, I guess, diversity can impact the way you presented it. So thank you. I applaud you for that. I have a couple of questions. How many patients have you, or how many, I should say, I guess, have you already enrolled in the study so far? And yeah, let's answer that one. And I have a couple more questions.
Okay, so far the average number that we've had for each session, as this has been strictly just for residents so far with what we've been permitted to do with administration, the average number is 6 to 7 each session. So with there being 4 completed so far, including a pilot study that we did, that would be around 25 of them. So it is definitely a smaller number, but it's us working with what we have given the department size.
And you have enrollees coming through every session, right? This is a 12-weekly session, so they...
Yes, yeah, we do. And so every session would be having about 5 to 6 of them.
And you have, so it's the same number that go through the 12 weeks, or you have some that get added on with every session, so you have a number that's growing now?
No, so for the project, it's the same exact group of people, the same cohort joining at the beginning and going through to the very end. So with the way we've structured it so far, once we start one of those cohorts, that's it. And we're not starting another one at that midway point or something like that. So we go from start to finish, focusing on those 6 to 7 participants, and then gather all the data and focus on them with that. And then we'll wait a few months before starting the next one.
I have one more question. How are you going to use this $500?
So the $500 would be used towards investing in more of the EEG, which so far we have been using the Muse headbands. So we would likely use most of it to invest towards that so that we can collect more of that data and have more of the scientifically validated versus simply relying on the answers that we get to those surveys.
Wonderful. Dr. Sundararajan, yeah.
Yes,
Questions?
yeah. Thank you, Kezia. That was a wonderful presentation.
Yeah.
And you laid out a roadmap, which is basically, feasible and reproducible. So I have a couple of questions. You have you been a participant yourself? And have you gone?
I have been a participant some, but I have not gone through the entire curriculum. I think it just hasn't worked out at this point because it's been so focused on residents and then
Sure.
their level of burnout they experience. I just haven't been incorporated as an actual participant. Also, since I am working on more of the research side.
Sure.
But yes, I have tested out the EEG and done meditation myself.
Okay. And what was your experience with doing the EEG, putting the EEG, the entire process? Do you think it's a, did you see any kind of roadblock and what is the perception of having to, have this as part of your project? Do you think, would that play a role in participation?
I would say, I think from what I have seen so far in my personal experience, having the EEG makes it more interesting to participants, and I think would be a big selling point to them, versus simply just coming in and having to basically sit in a circle, listen to a soundtrack that's guided by an ambassador, and then have to fill out another boring survey at the end. I think having technology involved definitely makes it more interesting. I would say the only drawbacks that I have seen is the EEG headbands are slightly finicky in terms of needing to wipe them cleanly with like alcohol swabs so that they connect properly. So that would be something we'd have to invest more time in up front with training ambassadors on how to put the headbands on correctly, so that we're not spending all that time to collect data that isn't even clean enough to analyze. I would say that would be the biggest challenge.
Okay, from the audience, there are two questions related to the methodology. One, what are you specifically looking for on the EEG? So that's that part. And then the first part is regarding that music. Are the differing cultural norms explained by those who are native to the culture to help participants who are unfamiliar with a culture gain new insight? How does music alone do this?
Okay, so for the first question with the EEG, I will say that based on current research that I have read that's been done, within about the 6-week period, there has already been an indication of the pathways reforming that basically connect to that feeling of happiness and satisfaction. And so what we would be looking for is continuation of that and evidence that from their baseline EEG that we would take over the course of the study, and by about the halfway point at 6 weeks, they would start to show the formation of those new pathways and indication of higher happiness and satisfaction levels. And then regarding the music and the background, I would say that in terms of cultural differences, we do want to use that as a platform to introduce people to different backgrounds. And we would be incorporating some sort of historic information about it so that people aren't just listening to random soundtracks, they understand where it's coming from.
Thank you. And then another question, thank you for your wonderful presentation. I find it interesting that you're a volunteer for the project instead of being paid for your work. Many underrepresented groups are not paid for the valuable work that they do. How do you plan on encouraging leaders to ensure appropriate compensation for work as it relates to your challenge of showing employees that they are valued?
Yeah, I would say that's definitely a challenge because I think in general, being at the trainee level, it's always difficult to get administration to be on your side with actually paying out, given all the financial struggles that departments can be in. So some of it, honestly, for me personally at least, has just been a struggle where I have to learn how to live on a minimum wage and like deal with a bit more of the scut work approach of going through scribing and everything else I need to do for experience. I would say it really is more about grinding it out at this point, even though in the best world possible, there would be better payments, but I'm not sure about key steps to getting to that point.
All right, thank you, Ms. Edmonds. We'll move on to our next participant, who is Dr. Cynthia Perez. Do you mind exchanging slides?
Yes.
Unmute yourself. We can see your slides, we can see you. And there may be a second mute button on the screen. not just on the telephone, perhaps. There you go. Go ahead. We can now hear you. Go for it.
Hear me and see me and everything. Okay. So much for allowing me to present at today's session. My name is Cynthia Perez, and I am a first-year neonatology fellow at New York Presbyterian Weill Cornell. My proposed project is titled Exploring the Role of Traditional and Technology-Assisted Translation During the Discharge of High-Risk NICU Infants of Parents with Limited English Proficiency in a Level 4 NICU. So to start off with a little bit of information about myself. As I said before, I'm a first-year NICU fellow at New York Presbyterian Weill Cornell, where I stayed on after completing my pediatrics residency here. During my time in residency, I served not only as a board member, but ultimately the president of the Pediatric Minority House Staff Committee, with its efforts focused on increasing diversity within the house staff and faculty level, in addition to strengthening pipeline programs as young as children at middle school age. My scholarly work also focuses on those marginalized and of minority backgrounds as early as my college years, with my first project interviewing Spanish-speaking families within low-income communities in California regarding aspects of their neighborhood that either promoted or hindered physical activity within their own neighborhood. And as of most recently, my residency project interviewed Spanish-speaking families of children with obesity at our obesity clinic in regards to their experience after the stay-at-home orders came into place with the COVID-19 pandemic, as it related to their mental health, their safety, their physical activity, and their diet. So why does this type of work inspire me? I am an only child to a single mother who emigrated here from Mexico when she was about my age. And so Spanish is our first language. So navigating this country, but in particularly the medical field, has not been easy. And I have had to serve as a translator in multiple contexts, including physician visits, where I had to translate for my own mother at our free clinics. So it's therefore my hope and my mission as a budding neonatologist to optimize the way that we as providers communicate with their families, with a specific focus on those whose primary language is not English. So moving on to my study, again, titled Exploring the Role of Traditional and Technology-Assisted Translation During the Discharge of High-Risk NICU Infants of Parents with Limited English Proficiency in a Level 4 NICU. I'd like to give a little bit of study background just to see what is out there currently in the literature. So just shy of 14% of New York residents report having limited English proficiency, with that being defined as those who do not speak English as his or her primary language at home, and who have the limited ability to read, speak, write, or understand English. Within the adult literature, patients with LEP are a known vulnerable population within medicine. They are often uninsured, fall below the federal poverty line in terms of their income, have less likely access to a primary care provider and therefore receive the adequate preventative care screening, and are more likely to return to the emergency room 72 hours after their last visit. In parallel, the NICU discharge is a complex process with many identified barriers. It is often documented that the NICU discharge process starts at admission. It's known to be complex and well documented to have many identified barriers, with communication being one of them, as even noted by our English proficient parents. The complexity of navigating discharge of an infant who may have multiple follow-up appointments, fortified feeds, medications that require precise measurement, and care of surgically placed support devices make effective communication and understanding of information absolutely vital. The Department of Health and Human Services requires that healthcare centers take reasonable steps to provide meaningful access to each individual with limited English proficiency. And despite being the gold standard, professional in-person translation services continue to be underutilized. There is a gap in the literature in that little is known about the use of different translation modalities, that being video interpretation, telephone interpretation, in-person, or language concordance between patient and provider, and its correlation to NICU discharge readiness and a safe transition home. So that's where my project comes into play. So the study questions that I aim to answer are threefold. What is the frequency of interpreter modalities used to communicate with parents having limited English proficiency? And how satisfied are parents with the aforementioned modalities? And are there any preventable gaps in communication that correlate to adverse patient safety events post-NICU discharge? With my specific aim being to investigate whether language concordance better prepares parents with limited English proficiency of high-risk NICU infants for a safe discharge home. Now, how do I aim to answer all of these questions? My study aims to be a prospective, retrospective, multi-method qualitative study that involves 20 parents of high-risk NICU infants who report having limited English proficiency. And high-risk NICU infants are defined as those requiring or qualifying for our neurodevelopmental clinic follow-up after discharge, which includes but is not limited to having a gestational age of less than 32 weeks after birth or at birth, a birth weight of less than 1,500 grams, requiring or being consulted for ECMO cannulation, or having a moderate to severe intraventricular hemorrhage. These parents would be recruited around the time of discharge and have a following 60-minute semi-structured interview 2 to 4 weeks after discharge. These interviews would be conducted in the parent's primary language, would be recorded with either a telephone call or a Zoom interview, and they would be conducted by recruited volunteers who also report having being of native language with that same language that the parent indicates. The second component of my study would include EMR access, or electronic medical record access for demographic data, length of stay, follow-up appointments or missed appointments, ER visits or readmissions up to 6 months after their discharge. These interviews would be recorded, transcribed, translated using a HIPAA-compliant translation and transcription company. They would be coded and undergo thematic analysis using an in vivo software. Parents would be compensated with a $25 gift card, hint, hint, $500 in total for all of our participants, as a thank you for participating in my study. Some of the questions would fall under demographic data to get a sense as to where our babies are being discharged home to, what the home environment looks like. A large chunk of the interview would include the NICU admission and the days leading up to discharge and day of discharge itself, with a particular focus on the way that the primary team communicated with family members and the usage of the different modalities, in addition to the perceptions of what families felt like using those modalities. And the last component would be what post-NICU discharge looks like and what home and the home environment and the transition there looks like as well. So who they're currently following up with, if they've had any difficulty attaining or following up with their providers, any ER visits or readmissions, and again, reviewing if they were prescribed any medications, how they've been given at home. My study has many strengths. Like I said before, there are currently no known studies specifying these interpretation modalities used during a NICU admission or discharge and associated outcomes within the NICU population. It also gives our families the opportunity to give an in-depth narrative, an opportunity to reflect on their NICU stay, and often giving them a voice that they may have not fully had during their NICU stay. My hope is that this study would not only give them the voice, but empower them to know that if any changes need to be made, they can be, thanks to them. It also introduces a diversity of languages to this body of research, as many of the studies investigating patients with limited English proficiency fall under Spanish-speaking populations, and my study will give the added benefit of recruiting family members who have backgrounds from all over the world, as our NICU does have evidence of patients who speak Cantonese, Mandarin, Urdu, Bengali. And we'd be able to not only recruit that from a patient population standpoint, but also diversify those that are participating in the research process itself through our interviewers, with the hopes of recruiting those that are to get them excited to participate in research too. And lastly, the study does not come without its limitations. First, the electronic medical record we use has a preferred language tab that may not always be the most reliable indicator of limited English proficiency. Some families may feel that they can just get by with speaking English, though they technically do fall under being limited English or having limited English proficiency. So I worry that we may be missing some families that way. Recall bias is also important. The first few weeks home with a newborn are difficult and sleep depriving, and a post-NICU parent is all of that plus more. So it could be that some of their, the days leading up to discharge and the day of discharge may be a bit blurred from that. And lastly, given that families would be compensated for their participation in the study, reporting bias also may come into play, as they may be more likely to favorably summarize their NICU stay. That being said, I would like to thank Dr. Zlame, Alachi, Dr. Howell, and my program director, Dr. Yap, for having helped me develop and organize my project to this point. So crossing many disciplines, their commitment to health equity has helped support me in my focus with this particularly vulnerable population in healthcare. And with that, I'm happy to take any questions.
All right, Sharks, we're up. You're up, Dr. Pat, Suhasini, or?
Yeah, I can start. Thank you so much for the presentation, Cynthia. I have a couple of questions. Did you start already recruiting?
I'm sorry?
Did you start recruiting families already?
Not yet. So this is
okay.
a project proposal that we're hoping to get in the grounds in the next couple of months.
Okay, because one of the questions that I was going to ask you, did you have any family turn you down, and what were the characteristics of the family? So the other thing that is a little confusing to me, what's the difference between traditional versus technology translations?
So a lot of the difference between the two is having a physical person, so an in-person interpreter, or having the patient provider concordance. So having a provider themselves be able to medically provide information within the patient's primary language versus using the telephone or using a video assisted interpreter. So that would be the two different modalities that are currently being used.
So in other words, you have the physician who speaks the same language. You have a phone, having somebody translating through the phone, or somebody translating to Zoom.
Exactly.
And that will be a translator, the physician, and the parent. So it will be a three-way.
Oh, so sorry. So for the methods, ideally, the person conducting the interview would be speaking in the primary language of the parent. So
the person conducting the interview.
Exactly. So if if these were of Spanish-speaking families, I myself would be doing them versus someone else who is native in Spanish, or if we have a family member who is speaking Cantonese, a recruited member who speaks Cantonese natively.
And that will be the traditional.
That would be that would technically, even though we are using the modalities of Zoom or a telephone, the exchange itself would be, I would say, then traditional.
So in other words, when you said technologies, what you're saying is the modality that you're using.
The modalities, exactly.
And what's the thematic analysis? You said we're going to look into the EMR and then there's going to be some thematic analysis. What is that?
Yeah, so the thematic analysis would mainly be drawn from the interviews themselves. So that would be looking at, overall what themes we're grabbing out of our interviews. If, if they in general are using more technology-assisted interpretation modalities, what their perceptions are, what their overall, like if there's any sort of either levels of distrust or actual, like, good perceptions out of certain different modalities. Those types of themes that would be, that ultimately would be coded would be going through, if that makes sense.
So what's the gut feeling that is going to happen? What are you going to find out?
So my hypothesis is that ideally either having an in-person interpreter where you're able to not only have the interpretation of the verbal aspects, but also the bodily aspects and the nonverbal cues, or having a provider themselves who is able to have that level of interaction as well with our parents, would ideally not be missing any gaps in communication and would provide a better outcome for our families going home. So that would be my hypothesis, but I'm open to hopefully, acknowledging that the other aspects that we are oftentimes more likely to use don't have those gaps in communication, but I fear that it'll be the latter or the former.
Thank you.
So, congratulations, Cynthia. I think you bring up a project that embraces diversity in our patient population. This is a little different focus from, of course, researching population, but I think it's a very, very relevant topic, and it resonates with all of our neonatologists, I think, here, who often face this challenge of a smooth transition for these parents, leave alone the ones who are language, challenged. It's even a NICU parent. So kudos. I think this is something that is probably adaptable to a lot of NICUs and a challenge. I have a couple of questions for you. The first one is, what is the population? I think you did allude to it a little bit, like you have some Bengali and Urdu and Cantonese population. I think the chunk, like you said, is probably Spanish. How easy is it to find interpreters in person in all of these with different backgrounds? I know translating service is available in multiple languages. Is it something common in your provider population that you're able to actually match people with the similar language, or you end up using the translating service or the other modalities more?
Great question. So historically, through New York Presbyterian, we are able to schedule interpreters in person ahead of time. So that is through, it does take a couple more steps, but often I have not had the issue where we don't offer that specific language, which is hopefully a good thing. But yes, it does take a couple more steps rather than having to call just a phone number or put in a code into an iPad. We do email ahead of time to see if they can make themselves available. But it has not been an issue that we haven't been able to get an in-person interpreter with a particular language.
And my other question is, the interviews that you planning to have with the parents, is it a pre-scripted, is it a script that every person who is going to, with different languages, they're going to use the same script, or is it different?
So ideally, it would all be around the same questions. So those would all be translated so that it could be readily available for everyone that's doing them. So there's hopefully some structure to them, but that with the caveat that they, some family members may be going off to on a different curve, which is okay. That's that's actually the beauty of some of our qualitative work that we
that's the beauty of qualitative studies. But you have the in vivo to pull out the themes from there anyway. So that's the good part. Awesome, very nice project.
Thank you. That was really good, Dr. Perez. I have only one question. I'm going to be short and brief because you clarified majority of the, the questions. So in your methodology, are you planning to interview the parents on the day of discharge as well? Or this is going to be, I see 2 to 4 weeks after discharge. Did you consider, or at least alerting these parents, who sign the consent? Are you giving like a questionnaire on the day of discharge, or, so that they know what to expect?
Yeah, so I kind of want to leave it open at this point because I'm trying to, not influence. So we know what is actively happening within our NICU, such that in the future we have potentially a pilot study to base a future qualitative improvement study off of. So my hope is that within the consent process, I would be verbalizing it in a way where, this is going to be a follow-up study to see how your transition home has been. Is it okay that if in 2 weeks to a month we have a sit-down study, a sit-down interview? So it would mostly be consent for that and EMR access about, their NICU stay and, 6 months after. But I don't want to skew them so much at that time. So I wouldn't be offering, I wouldn't be interviewing at that time or doing a survey at that time. But it's definitely something that's been kind of asked prior to as well.
All right, last 2 questions very quickly. I know you mentioned it, but what will you do with the $500, which I know you mentioned? And then last question very quickly is how this is an amazing, important project. However, I'm not sure if this increases diversity in research other than keeping you in reach when research, which should absolutely happen. That is a question on the chat.
Totally. So yes, those $500 are to the T exactly how much I would need in order to compensate my family members who would be participating in our study at 20 times $25 for each one. And I do feel like I would be increasing diversity in terms of, what is already present in the literature. As I noted before, a lot of it really does focus in, and I do also understand that maybe, a good portion of those that would be recruited in the study would be Spanish speaking, but I'd like to give, the added incorporation of those that don't speak Spanish and may speak in a different language that we have available here at our institution. And I want to promote diversity within the research realm too. So having those who are of a variety of backgrounds and have a variety of different languages spoken at home to get involved in the study and get excited for research as well.
Thank you so much, Dr. Perez. We will switch over now to Dr. Alicia Kinchette. Could you switch over slides and unmute yourself, Dr. Kinchette? We can see you, we can see your slides. You're still muted.
Hello, can you guys hear me?
Yes, now we can hear you. Go ahead.
Hi, my name is Alicia Quinchette. I'm a 3rd-year pediatric rheumatology fellow at the Children's Hospital of Montefiore, and I just wanted to say hello to everybody and thank you to the organizers of the Eastern Medical Research Conference for putting this Shark Tank idea together. I don't have any financial relationships to disclose. And then just a brief introduction of myself. As I mentioned, I am a 3rd-year pediatric rheumatology fellow. I am a 2nd-generation Black Dominican American. And my interest in medicine really peaked when I was diagnosed with lupus when I was 12. And as a patient going through a lot of these, like going through doctor's appointments, I was able to really understand health disparities, especially while I was going through my medical education. And when I was 18, I ended up having lupus nephritis, and during my residency, I ended up having a kidney transplant. So I really understand the healthcare systems from both angles. While I was in undergraduate, I actually participated in a pathway program that was called Audacious, and it really helped shape me like who I have become as a physician. They offered MCAT prep, tutoring, exposure to research, exposure to different medical schools. And it was really for socially disadvantaged and economically disadvantaged students. I went to medical school at New Jersey Medical School and participated in the Latino Medical Student Association, as well as the Student National Medical Association. I was really able to, because I worked in Newark, again, I saw what health disparities were, and really throughout my career, I was able to really understand what I can do and what I could potentially bring and help mitigate these disparities. While I was in residency, I ended up starting a diversity, equity, and inclusion program, and we were able to recruit the most diverse residency class that the program has seen, which I think speaks volumes because of the patient population that we were taking care of. They were a lot of minority patients. And then I started fellowship, and in the Bronx, again, it is a underserved community, and a lot of those patients came in with high acuity. And I decided to really take this opportunity to start to join the American College of Rheumatology Diversity Equity Task Force, as well as the CARA, which is Childhood Arthritis Rheumatology Research Alliance Task Force in Diversity, Equity, and Inclusion, to really just tackle these issues. My scholarly work focuses on implicit bias in pediatric rheumatologists and how that affects treatment recommendations, particularly in juvenile idiopathic arthritis. And I'm currently working on a quality improvement QI project about starting social determinants of health screening in the pediatric rheumatology clinic to really address the needs of our patient, as we know that medication adherence really affects clinical outcomes in these patients. So my personal mission is really to improve the health of all pediatric rheumatology patients by providing the highest quality of care and mitigating health disparities in pediatric rheumatology through health service research. So my particular proposal is to diversify the pediatric rheumatology research workforce through pathway programs. So just a little bit of background and why I think this is important is because number one, a lot of the diseases that are particularly with high morbidity and mortality affect minority patients. So socially disadvantaged patients with disease such as childhood onset lupus and juvenile idiopathic arthritis have worse clinical outcomes. They have higher mortality. They are more likely to be hospitalized. Patients with lupus have more kidney, cardiac, and neurologic manifestations compared to their white counterparts as well. And with juvenile idiopathic arthritis, they end up having more damage, joint damage, and disease. So why does this disparity exist? I mean, there are multiple reasons why we know health disparities exist, but one thing that I know that can affect patients' adherence to medical plans is patient-physician concordance. And there was a study that was done in adults that looked at SLE patients with discordant interactions. They reported poor communication with the provider. Also, we know that there are few Black, Indigenous, and people of color that are not proportionally represented in studies, and particularly in clinical trials. And there's limited research and even looking at how to mitigate healthcare disparities. And so with the lack of underrepresented providers in pediatric rheumatology, it could be harmful because you lack like the perspective of the value of different perspectives and values that can impact the researcher's approach to specific problems. URMs can really help add context to research findings of specific patient populations. And then also URMs can also help with recruitment approaches to disadvantaged groups. So in pediatric rheumatology, the workforce lacks diversity, with Hispanic, Black, and Native, Hawaiian, and Pacific Islanders really making 8.7, 1.3, and 0.9% respectively. And this was in a study done in 2005, the workforce study. So we know that we need more URMs in pediatric rheumatology. And exposure early on really helps to increase the likelihood of people joining rheumatology. There was a study done, it was called the RISK study, that looked at medical students and residents, and they had exposure during their training, and they had increased likelihood of considering a rheumatology career. So we can even go further than medical school and residency, and even go back further into college and college undergrads and graduates. So pathway programs have been shown to increase exposure to the medical field and aid students going into medical school or other master's programs. So I think if we can, the further back we go, the more likely we are to potentially have students and medical students and residents considering careers in rheumatology. So how do I propose to do this? Well, there is the Bronx Community Health Leaders, and this is a program that has been started in the Bronx by Dr. Robles. He's a physician in the Department of Family Medicine. And this is a pathway program for socioeconomically disadvantaged and underrepresented college and college graduates in the Bronx. He was able to publish his studies, his findings, and found that between 2014 and 2020, they had an overall acceptance rate of 86% in medical school, and the first 11 alumni went to obtain their medical degree. So the Children's Hospital at Montefiore is going to collaborate with the Bronx Community Health Leaders to create the Children's Hospital at Montefiore Community Health Leaders. This is something that is new and is still being worked out, but we're very excited about it. So the CHAM CHL program aims to increase the pre-health scholars' exposure to general and subspecialty pediatrics and improve their understanding on how patients' social circumstances can impact health outcomes. And then members will engage in shadowing, community service, mentorship, and research. So the aim of this study is really to increase exposure of pediatric rheumatology through clinical opportunities and lectures to underrepresented undergraduate and graduate students participating in the CHAM CHL program. Second aim is to increase the number of underrepresented undergraduate and graduate students participating in research in the CHAM Pediatric Rheumatology Division. And the third aim is to increase the number of underrepresented undergraduate and graduate students participating in the CHAM CHL program receiving formal mentorship. So this is a prospective, it would be a prospective study. The population would be around 40 to 50 undergraduate and graduate students, because that's usually, that's the amount of students that are usually enrolled in the program per year. And they would need to be participating in the CHAM CHL program. So the intervention, the rheumatology department will give a minimum of 3 lectures throughout the year, which would include topics about their career journey, pediatric rheumatology, just talking about rheumatology conditions, and then also about research opportunities that the division has. Interested students will spend 1 to 2 half days a week for 2 to 4 weeks in the pediatric rheumatology clinic. And then students will participate in research projects with the opportunity to start their own projects, particularly in health services. And then the study outcome really is just a pre and post questionnaire using Likert scale, assessing the likelihood of considering a career in pediatric rheumatology research, and their improvement in the overall knowledge of pediatric rheumatology since many people are unaware. Strengths and limitations. This is a novel approach to increasing URMs in pediatric rheumatology specifically. No studies have really assessed the use of pathway programs to increase awareness of pediatric rheumatology. They've looked at medical students and just an exposure, but not using pathway programs in particular. And then limitations, this would be a pilot study, and it's a limited number of students in one population in the Bronx. And then the CHAM, the actual program itself is a peer-run group. So students are the ones that are running it. So they're the ones who are going to pick if they want to join the division, do research, and really get involved with us. But at least they'll have a minimum of 3 lectures from us. And like I said, this is a short study and will require longitudinal assessment, really to understand if the students obtain a career in pediatric rheumatology and in pediatric rheumatology research. So in the future, this could be something that could be expanded to include the tri-state area and using already existing pathway programs. This doesn't have to, it's not creating the wheel. I think just getting rheumatology involved in particular pathway programs, but having a way to connect all of the pathway programs in general would be something that can be done. Considering sending these students to specific rheumatology scientific meetings, the American College of Rheumatology DEI task force is already sending first and second year medical students along with residents, but there's, I think that college graduates and college undergrads would also benefit from going to scientific meetings and then extending the mentorship and exposure after completion of the CHAM CHL program. So that way we just, it's not that we only see them at the CHAM CHL program, but potentially work with them throughout the rest of their medical training. Here are my references. And then please, thank you so much for taking the time to listen to my proposal. I'm open to any questions.
I guess to follow the same pattern, I go first. And this is amazing. Thank you so much, Alicia. And I have a couple of questions. How do the program will encourage networking first? And the second is this, the program itself, I'm not sure that you will know the answer, will address the greater depth of burden that minority physicians may face. Because one of the things that happen as a minority, you start collecting debt and debt and debt and debt. And a lot of these physicians don't want to continue into subspecialties because of the significant debt. Do you think that the program, not specific rheumatology, just the general program at some point will look into that?
So, I mean, the first one about networking, the program itself is going to have panel sessions throughout the year with residents, as well as attendings that are URMs to allow that networking opportunity for them to ask questions, as well as that network opportunity. And then in regards to, I mean, that would be great for all subspecialists. I mean, there is, during Advocacy Day, there is a, a bill that has already been passed to allow, to give funding to subspecialists, but there is actually no funding or money that has gone into that bill. So I think maybe advocating more, so that way they could get potential funding for that would be something that we can include, like for advocacy in general, that would be an aspect that would be interesting to add to the program, but it's not something that we considered during that time. But yeah, that is important.
Thank you so much.
Wonderful, Dr. Kinchette. That was a very good presentation. So I have one question. So you, I'm assuming you have still not started you listed the methodology, but you have, not enrolled your subjects yet. But how do you minimize any bias, going forward, your patient population, or your, talking about the multiple minority groups. So how are you going to choose those minorities?
The Bronx CHL program, the program already has the students selected. So we would not be selecting students to participate in the research. Like we would be giving lectures to all of the students that are participating. And the Bronx CHL, it's economically disadvantaged and also minority patients. So, like they had around 28% Black students, I think 41% Latino, 17% Asian. It's a wide variety of students, of patients that are from students that are from the Bronx. So I don't think that there's going to be bias in selecting of who participates, but more so it'll be the students who decide if they want to participate with us. So we would not be selecting. We're just going to give them the opportunity by giving them the different lectures and providing them with the opportunity to come to the clinics if they want to. Because like I said, it's a peer-run group. Like we can't force them to come. But hopefully with at least the minimum of the 3 lectures, they have some exposure. And if they want more, they're more than they're more than welcome to come and join us.
Thank you.
So congratulations, Alicia. I think what you have sort of re-emphasized is that pathway programs work and that this is a program that is easily reproducible and may work. So what is your specific role in this program?
So my specific role is setting up the lectures. Particularly, like I've actually done these lectures before this program even existed, but setting up the lectures. I have also am working with setting up the panel of discussions with the residents and the URM faculty. And then whenever we decide to actually start it, providing the students and undergrads with lists of the research opportunities and research opportunities that are available to them that they can get involved in. So that from my aspect is how I'm involved in that program itself. But like I said, this is the beginnings of, they're still looking for other subspecialties to get involved as well. So I think it's a great opportunity to jump in and really mold the program to what we want it to be. So,
of course, I won't spare you with the question. What are you going to use the $500 for?
Yeah, so I actually asked Dr. Robles because I wanted to know, because he knows the students the best, because they're his students, and he said Metro cards, and I think that would be a wonderful opportunity to mitigate like them coming and going to our division, to our clinic, coming to our department to work on research. So it would be for Metro cards.
Wonderful, thank you.
I have a question from, there's a question from the audience. Thank you for your wonderful presentation. How do you plan on getting buy-in for this pathway from your colleagues in the division, and what obstacles do you foresee in terms of obtaining buy-in?
Yeah, so luckily I have run this by our division, and there are several people that are interested, I would say half, that are interested in doing these, participating particularly in this program. Many of the division attendings already do lectures to other programs. So I think now focusing particularly on this CHAMP CHL program would be helpful in, like I mentioned, increasing awareness and exposure. So I don't think the buy-in is going to be difficult as they already participate in a lot of this. I think it's just going to be more focused on this particular program and really working closely with these students.
Thank you so much. All right, we're moving on to Dr. Dorsalis. Thank you, Dr. Kinchette. We will trade slides. I believe, Dr. Dorsalis, the committee is.
I have the slides, yeah. Okay, thank you.
So
Good evening.
just let me know when to advance them.
I will. Thank you. Good evening, everyone. Thank you for having this. I'm happy to participate, and I'm happy everyone's still with us at 5:30 in the evening. My name is Sandy Dorsalis, and I'm an assistant clinical professor here at NYU Lango Health in Long Island, and I'm also the assistant dean of diversity and inclusion here at the NYU Long Island School of Medicine. Next slide, please. So a little bit about me. I was born and raised in Brooklyn, New York. I am the eldest of 4 children, Tahitian immigrants. My mom and dad immigrated from Haiti over 50 years ago or so. I like to joke and say that I'm a New Yorker through and through. I went to City College. I then went to med school at New York College of Osteopathic Medicine. I did my residency at SUNY Downstate, and then I went on to do fellowship at Boston University, and then I came back to New York. Like I mentioned before, I'm currently an assistant clinical professor, and I'm also the assistant dean of diversity and inclusion for NYU LISOM. Next slide. So what I plan to talk about today is, like Dr. Alicia just mentioned, is a pathway program. We currently have a pathway program known as the Envision Scholars Academy. And what that program entails is high school and college students from our local high school in the area and some of our local colleges where they are actually mentored. They're mentored by the medical students here, where they put on a curriculum one Saturday a month for a total of 6 months. And the sessions are focused on clinical, they have clinical sessions, mentoring, and actual professional development. And so I am trying to start a subset of that where we introduce research, because I've noticed that a lot of our pathway programs are focused on the clinical aspects. However, a lot of our students are do not know about research, not aware of research. So I would like to start a summer research experience where we can expose them to the other side of medicine. So, like I said, it's a way to introduce research and demonstrate that there are other ways to contribute to medicine besides direct patient care. There's a need for researchers and innovations and advances in medicine. It's also a way to address the disparities in research. And it's also a way to have a positive impact on medical school admissions, of leading to clinical practice, and a way to develop critical thinkers. Next slide. So again, it's a way to introduce our college Envision scholars to research. It hopefully will foster an interest in research through hands-on experience and mentoring, and eventually lead to an increase in the URM faculty pool through direct linkage programs. Like studies have shown that the earlier you expose individuals, it piques an interest, and hopefully that can translate into more of them staying in our area and becoming part of our faculty. Next slide. So my goal is to pair the research faculty for 6 to 8 weeks during the summer. And our goal is to focus on basic research skills, and they can also be part of larger projects that are ongoing, such as cholesterol transport and atherosclerosis, disparities in chronic kidney disease using medical records, and also public health research on diet and cognitive function in children and older adults using publicly available data. So these are research that we currently have going on within the different departments, and we've contacted the faculty, and they're all on board and are willing to have student participants. We hope to provide a small stipend to the students, and we would like to end the research experience with the students putting on a small presentation of what they've learned throughout the 6 to 8 weeks that they've been on campus with us. Next slide. So the strengths of this is to introduce the students to field that they may have not been familiar with, try to increase the number of underrepresented groups in research, and hopefully build a network of mentorship and leadership, which can help bridge the disparity gap in research. Next slide. So some of the weaknesses of this is due to COVID restrictions. Our hospital currently has not allowed volunteers back But hopefully now that things are loosening up, I hope that by the summer we're able to get that so we can bring the students on. Stakeholder interest. And a lot of our participants may need to work full-time to provide for their families, et cetera, because again, we're targeting groups that are often financially constrained. So hopefully, this will be, the stipend will help them to mitigate some of those costs. Also, some of our students might not have access to transportation. And of course, funding. Funding is always an issue with any type of research or anything that we want to get off ground. Next slide, thank you. So I'm willing to answer any questions.
Right.
Go ahead, Shark.
Yep. So that was wonderful, Dr. Dorsalis. The initiative to encourage participants so that they can also have the exposure to research. But could you elaborate a little more how you're going to capture, how you're going to attract the participants? I mean, it is great that you're offering, a stipend, but what is the methodology? Are you going to give like an are you going to target undergrad students or within the medical school, or how are you going to attract the candidates?
So we already have our participants that are part of the Envision Scholars Academy. We have undergraduate students and high school students. So our target for right now would be the undergraduate students. We would have a different application process where they would complete the application to state whether they have interest in research. And from the applicants that we get, we would select the students from that. But our target right now are the undergraduate students that are already part of our Envision Scholars Academy.
Thank you.
You're welcome.
So congratulations, Dr. Dorsalis. This is a huge undertaking, and the proportions are massive. And like you said, I guess you have to have a buy-in from a lot of researchers and people who, researchers with labs, because if you're giving opportunities, I think you need to have mentors who are there, who are willing to mentor this group of, people who want to be in it. So you mentioned funding. So this, obviously this $500 is a little drop in the bucket. Do you have additional funding that is available for this project? And my other question is, are you part of this Envision Scholar Academy, like you are the boss, or you are the one who, like, where do you fall in this schema?
So, so the first part of your question, yes, I do have additional funding. I had approached our dean and our vice dean of the medical school, and they're very interested. So they have secured funding. So now we're just in the process of drawing up the proposal to get everything hopefully up and running for this summer. And in terms of the Envision Scholars Academy, I don't want to say I'm the boss. However, I am, I guess, the final stop in terms of making sure the program runs smoothly. It is a program run by the medical students. They have come up with the curriculum. They do a great job, and I'm just the final checkpoint to make sure it's addressing all of the objectives, making sure in terms of just housekeeping stuff. But I would honestly say that the bulk of the work is done by the medical students, and I'm just here as the, I guess, senior advisory person to make sure everything is run smoothly.
How are you able to get the buy-in from all these potential research labs and researchers who will enable these children to, go on their path?
Well, we're starting small, so that's always a good thing. Because we're starting small, we don't need too many people right now involved. Our goal is to start out with about 5 or 6 students. So that's one. Secondly, because we are a new and upcoming medical school, we are very interested in promoting research. So it's kind of a win-win for everyone. So I think that's why I'm able to get everyone involved and encouraged to do this.
Do you think this is reproducible in other settings?
I believe so. Of course, the major, I think, drawback would be, the faculty always need time. But I believe that the skills that we're trying to teach students, if you have a good post-bac or lab person, they can teach the students the basic science skills. And because these students have already shown an interest in medicine, a lot of them are willing to come and donate of their free time to work on longer projects. So I think that it's reproducible because they can work over the projects over the course of at graduating from college and going into medical school. So I do think it's possible.
Thank you.
Thank you.
Now my turn, last one this time. So how are you gonna measure success?
So I think I have a major success story. We actually have one of our Envision Scholars participants that applied to our medical school this year. So I think that speaks for itself. That's a major success. And in terms of the research, if we're able to get the research off the ground, we will be providing the students with surveys to see ways in which we can improve, if what suggestions they would make and ways to improve. So we are planning on producing surveys just to get feedback.
We had one question on the chat, which was related to, very similar to the other question, which was related to funding because of the extent of the project.
In terms of funding, I'm not sure where the money was from, but I have secured some funding, just a minimal fee, but I have secured funding for the project. So in terms of that, I think that it's a go.
All right, other questions from the audience or the sharks? If not, I will ask you for one final round if you had any additional ones if there are any other remaining questions from the committee to our participants or no?
I'm very happy we kept the time.
Okay, very good. So
I think Heather, do you have a question?
No, I just want to say this is super impressive. This is the first time we're doing it, so thank you to the committee. But really, thank you for all the panelists for presenting. I wish we had an award for each of you because you all deserve it. And I'm really, really impressed and inspired. And I do hope that you get involved, as you'll hear, in ESPR. You guys are amazing brains, amazing. It's just, I'm so inspired. So thank you.
Thank you.
Thank you, Dr.
For now, the sharks will deliberate and we'll hear from Dr. Bromberg, who is the president of ESPR. All right, sharks, see you later.
Thanks, Vivian. While the sharks are deliberating, I have a little commercial break for Eastern Society for Pediatric Research, so bear with me. This is everything you wanted to know about the ESPR, but we're afraid to ask. We are the largest of 4 regional societies of SPR with 389 members, including Connecticut, Delaware, District of Columbia, Maine, Maryland, Massachusetts, New Hampshire, New Jersey, Rhode Island, New York, Pennsylvania, Vermont, Virginia, and parts of Eastern Canada. As you can see, we're made up of the officers, myself, Julie Goodwin, who is our secretary, and Shemsa Goku, who is our treasurer, Jenny Lace, who's our administrative director, and our counselors, Ed Hurley, Jonathan Mincer, Jayshree Nair, who's also the planning committee chair, Pat Vugan, who you've seen today, and Vivian Yap, who you've seen today, and Carlos Oliveira. And as you can see, today is the last day to vote in the election. So if you are a member, please vote, because there's 2 counselors to be announced tomorrow. And first ever this year is our junior representative to the council. So we're trying to engage our junior members more. As far as our committees go, we have the planning committee chaired by Dr. Jayshree Nair and co-chaired by your co-host today, Dr. Vivian Yap. And sponsorship committee is chaired by Dr. Ranjit Kamedi. Membership, Dr. Nicole Spillane is our chair, and Dr. Melissa Langhan is the immediate past chair. And nominating committee is Dr. Adam Spanier. And you heard about the diversity, equity, and inclusion chair and co-chair today, and social media committee chaired by Dr. Beatrice Goylov. Our mission. The mission of ESPR is to foster development of multidisciplinary careers promoting pediatric research. It's important to note that our focus is on pediatric research, not just research by pediatricians. And our goals, to provide investigators, especially trainees and junior faculty members of all races, ethnicities, religions, sexual orientations, gender identities, and abilities with an opportunity to meet and present their research for critical review and feedback. Perhaps you forgot what a live meeting looks like. If you did, or if you never saw one with ESPR, we present not only research, but there's awards, including travel, meritorious science, diversity awards, mentor of the year, and case presentations. You can see what a poster presentation looked like in real life, as well as one of the folks who won Mentor of the Year with our past president, Jason Stoller, a past program chair, Mark Cicero, and a past poster award winner. We really want to promote networking and learning about job opportunities, and we're constantly trying to think creatively how to do that. So, if you have ideas or needs, let me know. And we're family friendly. We have a family pass for a small price so that your family can be there to see you present and support you, and breastfeeding room. But again, we're always looking to see how can we help and support our families and our presenters. So we are looking for creative ideas. There are 3 membership categories: faculty, allied health membership, which includes pediatric nurse practitioner, neonatal nurse practitioner, master of public health, pediatric physician assistant, and others, and junior membership available to masters of PhD candidates, medical students, residents, fellows, etc. Please consider, if you are not yet a member, joining. As you can see on the bottom, go to our website, www.easternspr.org, the membership tab, and just click where you see the gray button. And if you are already a member and you want to get more involved and learn about opportunities, email easternspr@gmail.com. Save the date for the in-person live meeting in Philadelphia at the Hilton Penn's Landing, Philadelphia, PA. We're very excited. Here's some sights of Philadelphia. And I really want to thank you. Please, again, refer to our website for some questions, and at www.easternspr.org. Yes. No, here we go. Let's see. Stop the share. All right. You guys are off the hook.
I'm so sorry. I, for some reason, can't start my video, but I will start off by saying we are back. We've come to a decision. I wish I had $2,000 so I could give everybody one of 500 at least. And most, I guess all of them scored very close. Some scored more on novelty, some scored more on impact, and some scored more on, I guess a lot of them scored on reproducibility and more on feasibility. I would actually hand over to Dr. Priya to finally make the announcement for the winner.
All right. And it was a difficult decision, as Dr. Kaushal pointed out, but the winner is Dr. Alicia Kinchette.
Wow, very good, excellent.
Congratulations, congratulations. And again, all the participants, kudos, all of you are winners. But just going with the mission of the DEI committee, Dr. Kinchette scored the highest in terms of feasibility and the reproducibility of this pathway to all the different sections of the community. So your work is truly commendable, and we wish you success and good luck. And please come back to us in a year and share the results. we would love to see the progress of your all this hard work and innovation. So again, like I said, kudos to all the participants.
Kudos to everybody. Congratulations.
Kudos. And then just to wrap up the session, as the chair, has been amazing. I think we learned a lot from you guys, and we would like to continue this conversation open. If you want to be part of our committee, please reach out to me or reach out to anybody. And two things I have to say. Mr. Cuban in season 4 said, follow the green, not the dream. And it was related to, I think, 2 women that they have a food truck and they want to open a business, a store. What we are saying here is you have to follow the dream, not the green. So thank you very, very much for your participation and for embracing the DIE initiatives that will create the space for historically underrepresented individuals to develop. Again, thank you so much. And I hope to see you everybody soon.